Mr. Chairman, this is a pleasure for me and honor to participate in this meeting. My talk is about self-monitoring blood glucose in fasting, a challenge or an opportunity in Ramadan fasting. I have no conflict of interest for this presentation. I spoke about challenges, opportunities of SMBG recommendation, and some recent study with a conclusion. What is the challenge? The first challenge is the physiological challenges with the risk of hypoglycemia and hyperglycemia, the impact of prolonged fasting on glucose variability. The second one is the cultural and psychosocial barriers with perception that SMBG break the fast, but this problem is solved in most cases. The stigma of fear of frequent testing, and finally, practical issues is limited access to devices or strips, the lack of patient education on SMBG protocols, and the transition for conventional self-monitoring to CGM. What are the opportunities? The opportunities is enhanced safety, timely identification of hypo and hyperglycemia, reduce emergency situation related to fasting, personalized diabetes management with adjusting insulin or oral medication, tailoring diet and physical activity. And the patient empowerment is that the SMBG provides real-time feedback to help patient make informed decision. For the recommendation, you know that the SMBG, we have one to test the number of blood glucose monitoring differs according to the case. We have many times to do that, but for the recommendation for patient is to test at critical times at pre-dawn, suhoor, midday, and pre-iftar, or if symptomatic or hypo or hyperglycemia. For the healthcare providers, they have to educate patients on safe fasting and SMBG techniques, use SMBG data to adjust treatment plans pre-Ramadan, and encourage the use of CGM if available. The more or the essential of information during Ramadan, it's to break fasting if the blood glucose is less than 70 milligram per deciliter or more than 300 milligram per deciliter, or if the patient have symptoms like hypoglycemia or acute illness occur. For type 1 diabetes, the self-monitoring blood glucose is crucial and must be frequent. For type 2, as soon as we are no longer in monotherapy, the SMBG can be reinforced. The doses of some OADs and insulin need to be adjusted off or even reduced. The use of CGM, of flash glucose monitoring, is superior to SMBG monitoring and should be the method of choice is if feasible. But we need to be careful because some data demonstrated that the accuracy of CGM data during Ramadan and in the gestational diabetes fasting need to be further studies. In elderly individuals must take at least 2 or 3 readings during fasting hours, 1-2 times during eating hours, and whenever they are symptomatic with hypoglycemia and hyperglycemia. This is now some data from a recent student. In 2021, this data from Ali Tuti summarize the study that it is documented that self-monitoring blood glucose is of vital importance for patients with type 1 diabetes who fast, and advantages of continuous monitoring glucose or flash glucose monitoring techniques should be highlighted. In the global survey conducted in more than 1,000 patients, and we have a question asked the patient, did you do self-monitoring during Ramadan, the education received before Ramadan, the method and duration. And the conclusion of this study is that almost 3/4 of the overall study population reportedly performed SMBG during Ramadan fasting. Moreover, 60% of the total population were educated about Ramadan fasting, among which 90% reportedly received the education during routine clinic conclusion education. This data is the comparison with association during fasting in Ramadan with hypoglycemia. And you have the glucose level monitoring timing in afternoon, pre-iftar, post-iftar. The second table shows the controlling blood glucose level among the diabetic patient. And the third one, the blood glucose level monitoring either alone or in a combination. And the conclusion of this study is the present study show that has helped in providing better understanding about the SMBG level and hypoglycemia. Furthermore, it's also emphasizes the pre-Ramadan education about when to break their fasting along with frequency and timing of SMBG. All the study show that the pre-Ramadan education is more essential for all patients. In this study, we study the diabetes gestational, but the conclusion said that the CGM detected more episodes of hypoglycemia and less hyperglycemia than SMBG in GDM patients during Ramadan fasting. The SMBG timing during fasting seems to focus more on times to detect postprandial hyperglycemia. It is very, very important in the diabetes gestational than on times to detect and prevent hypoglycemia. And relying on intermittent SMBG in the management of GDM, patients during Ramadan fasting might be misleading. The accuracy of CGM data during Ramadan fasting need to be further studies. Ramadan fasting among type 1 diabetes in this study who explore children and adolescent diabetic by itself, it's not associated with short-term glycemic deterioration. You know that type 1 diabetes now are allowed to fasting with condition. And in this conclusion that type 1 diabetes youths can fast safety in Ramadan with provision of focused education and regular SMBG. This is an interesting study from Global Survey 2020 and 2022 with interesting to the SMBG in patient receiving an intensive insulinotherapy. And fasting characteristic of intensive insulin using type 2 diabetes patients who participate in the DAR global survey of 2020 and 22 when grouped based on their self-monitoring of blood glucose at calculate by the IDF DAR risk stratification regarding this classification of the patient. The first group is indicated but not conducted, the SMBG with 2 points. The second one is indicated but conducted suboptimally, one score, 1 point, and conducted as indicated, 0 point. This is the result. The SMBG frequency of use. The table show that the second group with conducted suboptimally less than 1 SMBG daily have the priority for the patient, 30% for the Gulf countries, 50% for the Middle East and Turkey, 60% and 52% for the Indian subcontinent and Southeast of Asia. The conclusion is the patient in Ramadan don't do more than 1 self-monitoring blood glucose per day. The patient characteristic show that if we compare the treatment with metformin, DPP-4 inhibitors, thiazolinidione inhibitors, SGLT2, and receptor agonist of GLP-1, you have the percentage of realization of SMBG, 30%, 20% and 20% with no significant difference, but for the inhibitor of SGLT2. But what you use analog receptor of GLP-1, we have a significant difference with 1, 2.5 and 7.2% of patient. Hypoglycemia among those who fasted, we have who experienced hypoglycemia about 16, 19, and 26. But the incidence of hypoglycemia more than 8, we have 50% in the first group, 80% in the second group, and 70.9 with significant difference. The time of occurrence of hypoglycemia is between 9 and 12 p.m. in the three groups. For hyperglycemia among patients who fasted, we have 11%, 20%, and 30% in the three group with significant difference. The incidence of hyperglycemia is about around 36, 45, 24, and 29. And some patients have hospital admission or visits with no significant difference. The self-monitoring and education, the patient who not conduct SMBG have only 50% who have education pre-Ramadan. The most of education with the group, and if we have more than 30 minutes of education, only 1.5, 1.7, and 6.7 have more than 30 minutes. The time of pre-education, it's not enough. This study showed the self-monitoring blood glucose was practically by 35% of patients in 2022 and increased to 75 in 2022 with significant difference. In this study, with Diam Ramadan in Algeria, we just published, we have a difference between SMBG recommended and SMBG down in the patient. The patient do less number of SMBG that we have recommended that, and the number, it's about 38 for the low risk, 41 for the middle risk, and 40 for the high risk. My conclusion is the fasting during Ramadan involve unique challenges. The risk of hyperglycemia and hypoglycemia increases, requiring diligent planning and management. Pre-Ramadan education is key. The self-monitoring is crucial, especially in type 1 diabetes and type 2 diabetes with complication or middle risk or high risk. Personalized treatment plan matters, and advanced glucose monitoring support safety. Continuous glucose monitoring, CGM or FGM, provide real-time insight, particularly for those on insulinotherapy, enhancing fasting safety and glycemic control. Thank you for your attention.